Hello and welcome to another edition of the Osteopathic Lyceum podcast. We're going to talk about a relatively recent result from a student thesis experiment, and we're also going to relate that to something that's out there in the literature prior. So the general overview is that one of the students chose to ask people in advance of an assessment where they had notable pain with movement. So what they did was they gave them a checklist or just a general outline, and there was an opportunity for them to say that they felt pain here, there, or the other place. So essentially it was predefined areas that were to be assessed. So it was right shoulder, right side of neck, left side of neck, right side of low back, left side of low back, things like that. And then the student would be blind to that. So they would have the person fill it out and they wouldn't check it. And then they would do an assessment and they would identify where they found mechanical dysfunction with respect to the specific test that they used. So critique immediately that can come from it is, well, it wasn't free form for the person to report where they had pain. It was predefined by the pre-written areas that they could respond yes or no to. And then also, well, you didn't do absolutely every test, or you didn't do this particular test for motion. You did the test that the student determined. So within the limits of what was chosen on purpose by the student, what they were able to do was have the patient report where they felt pain generally, with, again, in predefined limits, and then they were able, with predefined sets of tests, to identify mechanical dysfunction and see if they matched. So the physical assessments or the motion-based assessments were located in the areas that the patients had the opportunity to say they had pain there or not, and located one side or the other. Generally, very, very broadly, what the student found was that about 50% of the time, where the person reported pain is where mechanical dysfunction was found. So you have this immediately apparent degree of difference. So 50% of the time, in the limits of what the student did, we found a match between mechanical dysfunction and location of pain, and a mismatch. So the actual percentage, as we have it here, it's 50.79% of the time mechanical dysfunction, the pain and mechanical dysfunction match, and then 49.21% of the time they're mismatched, right? So that's 50-50 across all of the possible sites that were predetermined. The thing that gets interesting is if we break it down into different areas of the body based on what the student found, so reported site of pain versus mechanical dysfunction found. When we look at the left shoulder, 45.45% of the time they match. So, again, that's 50%-ish. You run this out over more people, that probably hits 50%. The mismatch is 54.54, so it's the opposite. But again, that's probably 50% of the time. But then when we get to the right shoulder, so hopefully I said left shoulder the first time. I'm not sure. I can't rewind in real life. I can only rewind after I do this. But the right shoulder, it's essentially 66.66% of the time they match, and then 33.33% of the time they mismatch. So for some reason, a localization of pain report to the right shoulder more often than not matches the mechanical dysfunction. Then if we get into the back, right, so it says right side of back, it's about 80% of the time it's mismatched, right? So about 80% of the time that people report pain in the low back, there isn't a mechanical dysfunction noted, pain in the right side of the back. The mechanical dysfunction is not found there. It seems mechanically sound based on the tests chosen. Then we get essentially a flipping. So the left side of the back, you got 83.33% of the time when they say there's pain on the left side of the back, mechanical dysfunction is found on the left side of the back. So you've got this interesting switch for some reason. When you look at the right hip, 83% of the time it's mismatched. So they say pain in right hip, but the right hip seems mechanically sound within the limits of the tests that were performed. And then it's about 75% of the time the left hip, when pain is reported in the left hip, it matches mechanical dysfunction found, again, within the limits of the tests that were utilized. The left side of the neck, It's about 71.43% of the time they match, right? So the left side of the neck, for some reason, when people say they have pain there, you find mechanical dysfunction there at about 71.43% of the time. The right side of the neck, it's 50-50. So about 50% of the time, when they say there's pain on the right side of the neck, you find dysfunction within the limits of the tests that were utilized on the right side. So we've got this interesting variance location to location. That could be the experiment, that could be the tests that were utilized, but the broad thing is that regardless of area, it's about 50-50 when, again, within the limits of the tests that were utilized in this experiment, we see about 50% of the time where somebody says it hurts, it's mechanically dysfunctional, whereas 50% of the time that they report pain, it isn't mechanically dysfunctional. So we've got this phenomenon where the subjective report of pain doesn't necessarily seem to match the mechanical dysfunctions identifiable or that are identifiable. Now, this on some level matches some stuff that was done 2008, 2009 with it was primarily a group out of A.T. Still University or Kirksville College of Osteopathic Medicine. It is ATSU, but KCOM, I think the title properly still is KCOM, or the Kirksville College of Osteopathic Medicine, is housed within the larger institution of ATSU. ATSU has different schools within it. They do have a dental school. They've got a bunch of stuff going on, which is awesome. But the group was primarily KCOM based or ATSU based. The primary on both articles here is Donald R. Knoll from Rowan University, or at least Rowan University on the on when reported. So I don't know if Dr. Knoll was at Rowan at the time. This is semantics, doesn't matter that much. Anyways, what there is in 08 and 09, so they did COPD patients and they did elderly COPD patients. So they did a variety of single method osteopathic treatments on people with COPD, and then they measured at about 30 minutes post air trapping measures. So the second one, I think it's the 09 one, the 09 paper, they found that depending on the particular method used, varying measures of air trapping got worse. So it's like technique A, measurement 1 got worse, technique B, measurement 2 got worse, technique C, measurement 3 got worse. So it didn't match up which method, like that any method worsened the same thing, that varying methods worsened varying things. But what they did generally find, writ large in these two studies, so it's immediate effects of osteopathic manipulative treatment in elderly patients with chronic obstructive pulmonary disease, that's 08, and then the immediate effect of individual manipulation techniques on pulmonary function measures in persons with chronic obstructive pulmonary disease, that's 09. The writ large, they found that OMT applied to the thoracic region worsened air trapping. However, when you asked people if they were breathing better post-treatment, they generally said yes. So we have this phenomenon of measurable things not matching the sensation that the person is able to report. So it allows me to point back to something that I said a decent amount, that signs and symptoms are very different things. So signs are what anybody, including the patient, can identify, whereas symptoms are what only the patient can identify. So if you're asking people about their internal state and to report it, one of the challenges that you have is there is an unseen history of interpretation of physical sensations that that person possesses. You can't see the first time that they had a physical sensation and the second time and the third time, and how that coalesces into how they interpret physical sensations. So there can be a stable, obligate physical sensation, but it can be interpreted in different ways at different times. Or you could have a variety of physical sensations that are interpreted in the same way because there's some feature of them that's similar enough that the person interprets it that way. And then after that, you can't see the history of how that person had communicated sensations to others and then been impacted by the response. So you can't see, again, that unseen history of what the physical sensations have been, how they've been interpreted, how they've been communicated, and then how they've been reinterpreted. So you can't see that. So you have this phenomenon that is probably best described as a constructivist phenomenon, that the truth or that the piece of information that the person is going to report with respect to symptoms, so again, symptoms being what only the patient can identify, that internal state, that the communication of that internal state depends on the patient, their previous experiences, and the current environment of observation. So that is well described with constructivism, because the truth is highly dependent on the individual or the individuals involved. So you're asking for something that is highly variable within a person and between people, such that your ability to work with it, to target, is difficult because it's so variable. So colloquially, or maybe in a rough way, I will say I can't target feelings because I can't feel your feelings, because if I could, I would be feeling too many feelings, right? So my ability to interface with somebody when they present based on their symptoms is essentially, as far as accuracy is concerned, zero, right? It is best to assume your ability to interface with somebody's physical sensations as zero. Now, it doesn't mean you won't do something. It just means that because you can't observe it directly, you can only observe it through proxy. The proxies are going to be things like response to movement. So does it move all the way? If it does move all the way, is there resistance to the movement? If there is resistance to the movement, is it passive resistance or active resistance? When you generate the movement, does the patient provide verbal report of discomfort? Do they jump? Do they pull away? Something like that. So those are your proxies. You can get information that seems to point in the direction of something being uncomfortable at minimum, or painful at maximum, or maybe injury at maximum as you move them. So the ability to observe the feeling is only through proxy, and those proxies are going to then be the variable thing. So it's not that your ability to interface with how somebody feels is actually zero. It's just that it's inaccurate. It is highly variable. So you end up being better off interfacing with something that you can observe and you can target. Because if you can observe it, you can, in some way, whether rough or not, measure it and measure degree of change, again, in often a rough way, pre and post. So if you focus on how something's moving, so how far something's moving, or qualitatively how it's moving, so is there resistance to it? Is it pure plane or is it off plane? Is it notably different than its pair on the opposite side of the particular individual you're checking? If you go with those things, or say it's soft tissue and you put pressure on it and one area yields and another area doesn't, well, the area that doesn't, you can do some work to. So if it's anything above and beyond those previously mentioned approaches to identifying movement quantity and quality, you have to make assumptions, right? So if somebody says that their right shoulder hurts and I check their right shoulder out and the right shoulder moves okay, then I'm not going to be able to directly on the right side interface with whatever their subjective report is, because I can't target it. Yes, they reported pain. No, I didn't find mechanical obstruction or dysfunction. So my actual methods and my approaches probably won't match what they're reporting properly, because my assessment says it's okay. Now, if I'm a little bit more diligent and I move into soft tissues and I find an area in the soft tissue that isn't moving as well as it could, well, there you go. I just had to change the test that I utilized, and I would be able to find that mechanical dysfunction, or that smaller, more pointed, more localized mechanical dysfunction. But if I do that and it's not there, then yeah, I can't work on the right shoulder because my methods don't line up with what I found in the right shoulder. Whereas, in the left shoulder, say somebody says there's pain in their right shoulder and right shoulder's fine, even when I do kind of more minute soft tissue checking, and the left shoulder's a mess. I'm like, I know that you're complaining of pain in your right shoulder. However, your left shoulder isn't working particularly well. That's the thing that I can deal with properly, because it's about what I find that isn't moving properly. Then alternately, if you consider the inability to be accurate to the the matching of physical findings and subjective report, one of the things that you can do is simply pay attention to the area in some way, check it. Sometimes the checking of something and saying mechanically it's sound will alleviate some of the psychological, emotional aspects of what the person's reporting. Sometimes it can feel dismissive. You can apply some kind of method very gently, and maybe sometimes that gives them the psychological and emotional input that allows them to feel like they were paid attention to, right? But mechanically and based on your findings, it's not necessarily a good match. So what the findings from Noel and the group at ATSU with respect to COPD, air trapping getting worse, as well as with respect to the positive patient report of feeling like they could breathe better. So seeing that disconnect also from the student here at the Osteopathic Lyceum asking where somebody feels pain, right or left, this area, that area, and then assessing for mechanical dysfunctions, again, within the limits of the test that they used, and finding it's about a 50% match. What we can then do is start to acknowledge better that the report of pain does not necessarily, or not pain, the report of physical sensation may not consistently match more observable findings, right? So feelings are hard to observe at best by proxy, whereas movement characteristics, or you could call, I guess, air trapping measurements movement characteristics because it's the movement of pressurized flow from one area to another. Yeah, I guess you could call it that. So kind of movement characteristics, measurable movement characteristics. So maybe try to make this cleaner. Patient report will not consistently match mechanical finding or observable, measurable mechanical finding, such that we have to acknowledge that depending on what the person's primary concern is, our methods may not necessarily accurately be able to interface with it. It doesn't mean we can't, as people, interface with that person. So practitioners and patients, there can be a crossover where even the increased confidence to know that the thing that's hurting is moving okay, and that even though it's moving okay, we apply some form of mechanical intervention, and it either feels the same or it feels different. Then if it doesn't feel different, we can identify that an appropriate intervention may be something else. It may be some form of anti-inflammatory. It may be some other form of healthcare intervention, something different. We can start to acknowledge maybe better that it would be easier for us to figure out when referring is more useful for a particular individual. And that comes from the root of starting to acknowledge that physical or sensation report does not necessarily match mechanical findings with some level of consistency. Therefore, our interventions could be predicted to be less useful under those circumstances. It is not that our interventions would never be useful. It's just that we can then start to figure out the rate at which mechanical dysfunction mismatched to physical sensation report, or maybe say this another way, patient report of discomfort in a particular area, no mechanical dysfunction found in that area, treatment of mechanical dysfunction found in another area, we can then start to calculate the rate at which the mechanical dysfunction treated in another area will have a positive impact on the area that has been reported uncomfortable, right? So we can actually start to figure that out, but we have to at least start with the groundwork of observing that physical sensation report and mechanical findings or physical findings don't match all the time. What we would need to do is play this out over more people and find a more robust rate at which they differ. I would assume that even in the areas where we see, let's say, right side versus left side, it's more mismatched on the right side and less mismatched on the left side with respect to how often pain report and mechanical dysfunction line up. I would assume, given enough time and enough people, that would start to run closer to 50%. It would be my assumption, and I could be wrong, but we can probably play this out over time. And if we play it out long enough and figure out that there is a consistent rate at which physical findings and patient report do not match, then what we can do is set up the next step and say, okay, how often, so when we find areas where it does not match, how often when we treat the area that is mechanically dysfunctional does subjective report change? Then we start to understand how often we're going to likely be successful under those circumstances. So it's a really interesting finding. Blake Zimmerman is the student. I'll try to get Blake to talk about the experiment in future, but Blake did a pretty good job, identified a pretty interesting phenomenon, and we have something to build from with his identification of this phenomenon and observation of the phenomenon. So we actually seem to be making some headway that I find interesting. I hope you do too. So thank you for listening this far. Hopefully you learned something, and we'll talk again soon.